reasons why I like to work at Rouge Valley. I love the people. I love the leadership team, and I like the fact that we are really focused on quality. And what I find with our leadership team is that we're all on the same page. And in fact, Amelia and John have already said some of the things that I wanted to say. They stole my lines because the Chief Financial Officer told us that quality costs less. Good quality costs less. Amelia said it's all about quality, and that's really what I wanted to talk about too. So I love the fact that I'm working at a place where we're all on the same page and we all take quality really, really seriously. It's not just lip service. So I'm going to talk a little bit about some of the quality indicators that we looked at last year, and I'm going to go through the scorecard for the month of February. We don't have March yet, but it takes a few weeks to put it together. So I'll talk about February, and then I have one slide that will talk about some of the quality indicators we're really focusing on for this coming fiscal year, which just started. Okay. So this is our corporate scorecard. We talk about it at every town hall. If you're seeing it for the first time, where there's green, that's a really good thing. Red is not such a good thing. Red is where we have opportunities to improve. And yellow is where we need to be keeping a watch on how things are going. So this first page for the month of February shows our indicators that are related to service excellence. And the three big ones that we report on every month here are our mortality rate, so the number of patients that are dying, the percentage of patients that came in and they died. And we want that to be as low as possible. And I have to talk about this one because you'll see that it's not green, and it's not yellow, and it's not red. And there's a reason for that, why we've done it in black. It's that because we were using one way of calculating this figure for the last 5 years or so, and just in the last few weeks, the Canadian Institute for Health Information, CIHI, they're the ones that analyze this data for us and give us our results. They changed the whole methodology. So everything has changed. They redid all of the past years using a new methodology. So this is the very first time that we are actually reporting these numbers in this way. And it's a little bit different than what we have been reporting all along. So what this shows is that the national average is now reset at 100. And what that means is that if you're at 100, then the actual number of patients that died in your hospital was equal to the number that we expected to die. Okay? And that is what the national average for the country is. It's 100. So if you're above 100, that means that a few more people died than were expected to. And if you're below, that means fewer people died than were expected to. So under the new methodology that they've done, we're showing that we're higher than 100. And that more people died than expected. And that is up to the second quarter. It's old data. It only goes to September, which was the end of the second quarter. Our rates are actually much lower than this if you were to look at them today, because we've gone back and we've reviewed all our charts, made sure that things were coded correctly, because you get to take people that are palliative, that they come into the hospital and they have a terminal illness, and they're going to die and they're getting palliative care. They are supposed to be taken out of these figures. So when you are able to identify palliative cases, the number gets lower. So we had a bit of work to do on that because, we had some work to do on that because we weren't always picking up those palliative cases. So we've done a review of that. So we'll be resubmitting the numbers for Q1 and Q2. So what you'll actually see when all is said and done, I'm pretty sure will be a much lower number than that. But we have a lot of things in place to help us keep our mortality rate low. In addition to looking at how we code and how we document, we're really focusing on evidence-based best practices and really encouraging our clinical staff to use order sets and care pathways that give us consistent evidence of the best way to do things. So that's a big focus. Hand hygiene, you know about already. We're in the green there. And patient satisfaction, we're actually in the green as well, and we haven't always been. So we're seeing a positive trend in our patient satisfaction figures going up, so that's good news. The next category of things that we're looking at is fiscal responsibility, because obviously we do need money to pay all the excellent workers that provide quality care and to buy the equipment, etc. So it's important, and we have a positive budget variance. We're in the green, which is wonderful, and thanks to everyone for their hard work on that. That's allowing us to end the year with with a surplus so that we can reinvest in the infrastructure and the equipment that we need to provide even better care next year. Our volumes are looking good. Where we are in the red, though, is conservable days, and that means patients are staying a bit longer than you would expect them to. And we need to do some work on that. That's one that we've struggled with for a long time. And one thing I want to emphasize about conservable days is that it's a hospital-wide issue. It's not just about patients and medicine or surgery not being discharged on time. You can actually get conservable days even at the beginning, because a lot of our patients come into the emergency department and may stay there for 2 or 3 or even 4 days. And if we don't get things going to prevent deconditioning and get the order sets going and get swabs done and all of those things, that could actually contribute to them staying longer than expected. So it's not all about what happens at the end, it's what happens all the way through the patient journey. Now, access to care is another area that we track, and I'm just going to highlight a few of these. Most of our wait time indicators are green, so that's a great thing. The one that is in the red that keeps challenging us is the wait time for admitted patients. So as I just said, a lot of our patients come to the emergency department and we identify that they need to be admitted to a bed, but it's taking a long time for that bed to become available. So our target at the Ajax site is 56 hours. So more than 2 days is actually our target. And at the Centenary site, our target is 43 hours, 42.8 hours. And we're not meeting that at either site, but there are a lot of things in place that we're working on to help us improve our flow to get patients to a bed faster. Because we all know if it was you or your child or your mother or your father, you would be very concerned if they were in the emergency department for 3 or 4 days. And that's what we're trying to improve. We're also tracking sick time here, and it's green for this month, so that's fantastic. The month of February, it was in the green. Our target is 4.25, and we were at 3.8. And we haven't seen that happen very often, so congratulations to everyone on that indicator. Mortality rate. Okay, preventing the deaths that we can prevent. We also look at patient satisfaction. We want everyone focused on that. We also want to focus on connecting people back to the community when they leave the hospital. So we want to make sure that if you have a family physician, that family physician knows that you were in the hospital, and when you're discharged, they get a copy of the discharge summary as soon as possible. Ideally, before you go to see them for your follow-up appointment. So that's one of our top indicators for next year. And pressure ulcers and falls in complex continuing care. So keeping those really vulnerable, frail elderly patients as safe as possible by preventing pressure ulcers and falls. So those are our 5 indicators in the service excellence category. And you'll note that we have more indicators in service excellence than any other category. And I hope that really sends a strong message that we're very, very focused on quality at Rouge Valley. Access, we have 2 indicators. One of them you know about, the wait time for admitted patients in the emergency department. I've talked about that already. Another one that's new on our list this year has to do with elective hip and knee replacement surgery. As you know, you hear a lot about this in the media. We have long wait times in Ontario often for hip and knee replacement surgery. But the focus really is not just on wait times, it's also on quality. And what the government has asked us to start to track and report on is what proportion of people that come here and have hip and knee replacements actually get discharged home. Okay? They don't end up going to a long-term care facility, for example. So what is that proportion? So that's a new indicator that we're going to track, and it's one that's very important to us. It's also going to be tied to the quality-based funding, the new funding model that John talked about. That's one of the indicators where the government will be comparing our cost per case and our quality and for hip and knee replacements with all of the other hospitals, and only the best hospitals will be the ones that continue to get funding to do hip and knee replacements. So it's really, really critical that we do a good job on our wait times and our quality indicators for hip and knees if we want to continue to be funded to do those in the future. We have 2 indicators on our top 10 related to team engagement. One is staff satisfaction, and the other, John mentioned how important lean is. We're going to continue to work on that. The final indicator, there's only one on the top 10 for fiscal responsibility, and it's the total margin. and that's the one I said it is in the green. We're doing really, really well, and we just want to continue to do that so that we can invest where we need to.